Good morning. I'd like to welcome everyone to the session and thank you for joining us today. The live transcript is available if required. If you prefer to hide it, click on the live transcript button and select the hide subtitles. The session will be recorded and the link will be sent to you afterwards. It will be available to view at the website. Please use the Q&A function if you have any questions during the Q&A, and that will be answered during the Q&A session at the end. Feel free to use the chat to introduce yourselves and general comments. With that, it is my pleasure to introduce our speaker, none other than Dr. Mathew Diggle. Dr. Diggle is a consultant clinical microbiologist with over 25 years of experience in acute diagnostic and reference services across the UK and Canada. He trained in Glasgow and London, spending a decade in Scotland before moving to Nottingham, where he held the senior NHS roles and contributed to research within the National Institute of Health Research. Since 2019, he has been serving as a clinical microbiologist in Alberta, Canada, where he directs clinical microbiology fellowship program at the University of Alberta and leads provincial respiratory infection initiatives. His expertise include rapid molecular diagnostics, biodefense, and diabetic foot infections, where he has contributed to international guidelines and respiratory pathogens. Dr. Diggle is actively involved in the Microbiology Society as the Deputy Editor-in-Chief for the Journal of Medical Microbiology, and he is passionate about global microbiology education and nurturing the next generation of pathology leaders. Over to you, Matt.
Thank you very much. Good morning, good day, and good afternoon, everybody. So thank you for the opportunity to present today, and thanks to the organization and the organizers for giving me this chance and that kind introduction as well. So what I'll do is I'll attempt over the next hour or so to discuss various aspects of some unique trends and epidemiological features of respiratory disease, both globally and also more locally within Canada and also within my own province of Alberta. As mentioned in the very kind introduction, my primary role is as a clinician here in the hospital, so I'm not a full-time academic. So a lot of what you'll see in terms of the data I provide locally will be from my day-to-day work within the province and my day-to-day activities. There's always an attempt for me to try and translate that into academic and have the opportunity to present it to my colleagues such as today, but I'm always open to collaboration. So if anybody wants to collaborate, I think that's really important. So in terms of objectives for today, well, I've listed a few fairly high level and I'll go through them, I suppose, at a fairly good pace in terms of then I want to cover quite a lot of ground. In terms of objectives, as I mentioned, we'll be looking at recent and projected global trends, both viral and bacterial respiratory infections. There'll be some focus on certain bugs, so like influenza, RSV, human metapneumovirus, and even, I'll say the C word, COVID-19, sorry, apologies, along with recent surges in some interesting respiratory bacterial infections like Mycoplasma pneumoniae. There'll be a little bit more detail as well. So I'll go through general global epidemiology and then a little bit more detail, as I said, within my province of Alberta. So in terms of a starting point, what does normal look like? We've had, shall we say, a little bit of a topsy-turvy couple of years in terms of what do we think normal looks like from a respiratory disease perspective. So as a point of reference, knowing that COVID has been around for a number of years now, and it's been a very common topic, I'm sure lots of you have seen presentations on it, there are actually a number of other respiratory pathogens that do circulate and do cause disease, so they do keep us busy. In fact, for those who are not directly related into the field, and again, I'll try and balance this as I move on, there are a number of different pathogens that we regularly identify as part of any kind of clinical respiratory workup. With this in mind, in terms of for my service here, I've given some examples, and I'll go into some detail a little bit later on, but we test over 20 different pathogens, respiratory pathogens within the province here for symptomatic patients. And it's that kind of data that I will explore in a little bit more detail within Alberta. Suffice to say that the ones that you would normally see, excluding SARS-CoV-2, I've listed a few of them here. So the likes of enterovirus, rhinovirus, your flus and paraflus as well. So further highlighting that, and again, I just wanted to kind of just really give a good example again of what it looks like in terms of distribution. Here is, I've just combined 3 studies over 2 hospitals, again within Alberta, but it's fairly representative as what we would see in many other countries as well, certainly within the winter seasons for the Northern Hemisphere, and then the flip of the winter seasons in the Southern Hemisphere, which they're just about going into. And you can see in this particular slide, if I was just to summarize it, effectively you're looking at around about just over 50%, around about 55% that are non-influenza respiratory viruses. So there's a lot of thought about, well, it's always going to be flu that circulates around. Flu and man flu, of course, but actually differentiating that, we can see that there's actually quite a lot, over half, that are non-influenza as well. So yes, we do have a lot of flu that circulates around. We have a lot of other different pathogens as well. So again, that's the reason why I want to focus on a few of those at the same time. So looking at more recent publication data, I kind of surmised together global respiratory disease landscape, or the landscape over the last couple of years, and looking at the emerging patterns of various different viral and bacterial pathogens, and also the public health responses to those. And so what I've done is I've gone and taken the liberty of separating that into 6 different areas to start off with my kind of global picture. And given the time limitations, I'll only briefly touch upon these as we work through before then we dive into some detail within Alberta. So those I've listed are viral pathogen dynamics. So in other words, the key messages related to viral respiratory pathogens and infections, that's really important. The importance of bacterial co-infections, again, that is a complication clinical and laboratory, and also complicated in terms of outcomes, so important to focus on. How the public health responds to and supports these challenges. Again, that's very important. New and emerging threats and horizon scanning. Again, just kind of making sure that we are prepared, and then linking in with that prepared strategies and just ensuring we've got system memory. This is not the first time that we've gone through a pandemic-like response with regards to COVID. If people remember kind of SARS and MERS as being some smaller examples, and so it's important to have system memory on how we cope with that and use some of the experience. And then finally, key challenges. So in other words, how do we strive to improve on previous responses and our experiences? So tying that all together. So hopefully I'll give you a nice little summary of kind of how globally that looks like, or certainly the trends moving forward over the last couple of years. So starting off, looking at viral pathogen dynamics, influenza A has for the longest time has been a common participant in these settings. Globally, influenza A remains highly active. So we tend to find that we get a 20% positivity rate within the season, and that was no different in 2025. And we started to see that increase. So in other words, that 20% positivity rate starts to peak, certainly in the Northern Hemisphere, and we see that month on month increase. So a good example is that from January to December, we saw in many countries in the Northern Hemisphere a 2-3% increase in positivity rate as we see that surge. And certainly in the Northern Hemisphere, and again, I'll focus on the data that I have here, but I will touch upon the Southern Hemisphere being vitally important in providing us with surveillance data. But in the Northern Hemisphere, a lot of that data as we come out of our winter showed high transmission again, no surprise. And when we often look at the subtypes, as we do for this particular season, we see that H1N1, the avian flu, and especially PDM09, which is effectively the H1N1 2009 strain, and also then the H3N2, which is our human seasonal flu strain, are the two that circulated around as being predominant for the season. So in terms of these subtypes, where were they distributed in terms of then their seasonal, their geographical variation? Well, we saw H1N1, PDM09, or the 2009 dominant in Europe, West and Central Africa, and also in Asia. But there was a variation with H3N2 being a primary subtype in North Africa and the Caribbean and Central America. So really important to obviously start to understand the different subtypes and how they circulate around different countries. In addition to that, we also have co-infection. So we have both subtypes that circulate at the same time or simultaneously in multiple different regions as well. Complicating all of that as well is that within specific regions, we get variations within regions. So giving good examples, if we look at the recent winter, in Europe, there was only maybe about half, so I think it was about 16 out of 30 of the European countries said that they exceeded their what's called their influenza-like illness baselines. And some notable examples would have been Italy and Switzerland that reported higher than pre-pandemic activity. So it's really interesting to note that one size doesn't fit all. So when we assume in Europe that we have a certain trend, once we start to do a deep dive, there's going to be variation within countries as well, within certain regions. So it's just to note that out. In North America, we saw pediatric hospitalizations that rose sharply. So again, that was no different from many other countries. And as I mentioned, in Asia, we saw sustained H1N1 2009 dominate across multiple different countries. So considering the severity of disease, and again, this is something that's really quite important, and certainly within my realm as well, we start to then say we test, we attempt to interpret, but we also look at severity of disease as well. And so how do we do that? Well, I'll show some slides later on within Alberta as well, but certainly from a global perspective, we look at hospitalization rates. And so again, when we look at certain countries like the United Kingdom and England, they showed high levels of reported cases of influenza and also intensive care unit admissions. And again, that is something else. So the three things that generally a lot of countries will look at is going to be hospitalizations. It's going to be intensive care unit admissions. So in other words, where we find patients that need a lot more help in the hospital. And then unfortunately, we're going to look at severe outcome in terms of mortality and death. So those are the kind of three things we would look at in terms of severity of disease. In terms of then surveillance data, and again, this is really important, the WHO is obviously a bedrock in this. And so they've reported elevated levels of flu A, not surprisingly, in lots of different countries. So Eastern Africa, they look at Oceania and the Southern Hemisphere. And again, I'll touch upon that as well later on. And PAHO also in South America look at their trends. And certainly they start to indicate in their season as they enter this particular season on looking at the severity of their disease and the circulation of their subtypes. And that can certainly, as they go through their winter, and I'll talk about this in a little bit more detail, drive our understanding of when we start to then enter our winter in terms of 2025, 2026. Sorry, I'm just about getting over the winter here in Alberta. So talking about winter 2025, 26 is just slightly traumatic. So I'll try and not mention that again. So overall then, in terms of a message, we're looking at, if we're going to say a key message to this, influenza A, H1N1, H3N2 are the subtypes that have driven surges in the winter we've just seen. Excuse me. So given the changes in dynamics of both available vaccines and new treatments for RSV, this has been one to note for this season as well. So it's one that I wanted to try and identify in terms of global spread. So interestingly, RSV has seen decline in activity observed in some regions in the Caribbean, while in North America, and certainly within my region as well, we've seen late surges and certainly pediatric surges. So we've seen a lot of kiddos that are coming into the hospital, and we've seen a lot of them being diagnosed with RSV. So there is a hope for a new infant vaccine. I say vaccines, and I will touch upon this. This is a challenge for all of us within this community in terms of emphasizing the importance of immunizations. But certainly with the aim of being very proactive in reducing hospitalizations, much in the same way as we'd want to look at the data for the over 65 populations in many studies for RSV. And again, I'll touch upon in some detail some of the really interesting work that's come out of that globally. So when we consider the pediatric burden, RSV cases result in around about 3.5 million annual hospitalizations a year and report around about approximately 100,000 deaths in children globally under the age of 5, which is quite incredible. 97% of those occur in low and middle income countries. I'm passionate about equity of care, equity access of care, equity of access of resources as well. And so that stat in itself will tell you that we have available expertise, we have available resources, really need to work in terms of just making sure that our colleagues on this planet have the same access that many other countries might have, and RSV vaccine being one of those. So infants under the age of 6 months account for about half of all pediatric deaths. So we really want to try and look at making sure that that's as preventable as possible. When we add in the adult impact on this, in high-income countries, RSV leads to around about 150, 160,000 hospitalizations and around 10,000 deaths. So a lot less, but again, something that can be prevented. And if I use my Canadian data, this shows around about 9% of in-hospital mortality in older adults, and around about 16% of RSV hospitalizations are requiring intensive care unit care. So a lot more effort required to make sure that we can get hopefully a positive outcome. So when we look at regional trends for RSV, again, I touched upon it in North America, we've been seeing surges. So we've been seeing a lot of activity with pediatric hospitalizations. And in some regions, we've noted upwards of a 30% positivity rate for RSV, which is quite incredible. I mentioned, interest enough, in the Caribbean, they've seen declining activities from January 2025, which is obviously a really great sign. But then the flip of that, when we look at China, they account for around about 50% of the global RSV burden in children under the age of 5. So again, what can we do to help in terms of just making sure that we can reduce that as much as possible? Is there any impact in terms of seasonality? Well, we normally find that in the temperate regions, we see around about a 5-month seasonal epidemic. So these start in the late autumn/fall. I'm used to saying autumn. And then they go through the winter, while in tropical areas, they may experience much more prolonged high circulation without any clear peaks. So again, it's about understanding how in different countries and different regions, how the climate can affect that. And certainly considering post-COVID as well, as many regions are reporting resurgences in certain diseases like RSV, certainly when they've started to relax what's called NPIs, which is non-pharmaceutical interventions. So when we start to look at, for example, a reduction in mask wearing, or people start to relax the way in which they are doing preventative measures like washing hands or social distancing, we start to see a surge in certain infections as well. So some of it is not necessarily a surprise, but we obviously have to manage that as well. And as mentioned earlier about vaccine progress, it's really important that we start to look at vaccines to prevent severe disease. And there's some data coming out of high-income countries that I mentioned, which looks really positive. And so we want to try and look at how we can provide equity of care. And certainly there is a lot of evidence to show that there is coverage gaps. Excuse me. So coverage gaps remain persistent in low and middle income countries. So, and vaccinations is a really key topic in terms of how we can, excuse me, how we can make sure that vaccines are available in equal measure in low and middle income countries compared to high income countries. So overall, we do have available vaccines, we do have available treatments. We have seen, however, high hospitalization rates matching that of previous peaks, which is frustrating because we are starting to get effective treatments and vaccines. Here we go, the slide. So now I didn't want to COVID you all to sleep, but I will go through this as quickly as I possibly can in terms of wanting to focus on other things as well. But suffice to say that there are many different variants over the years, and currently the COVID-19 variant of interest when you go onto the WHO website, and certainly for us here, is JN.1, and it's projected to dominate in terms of over these next few years. I will throw out some variants to you. They are just letters and numbers to me. I will defer to those that are experts in it, but KP3 and LB1, as well as XEC and LP8. I'm sure it's tests everybody's memory in terms of how we arrive at all of these. But these are some of the variants, and I would encourage people to go onto the WHO website and to go onto various different resources to look at actually how they're monitoring these variants of interest. Again, looking into my world a little bit, we look at cases and death trends, and we've seen a decline in cases, which is great, and we see a continued decline in cases. And so what does that mean globally? We're seeing around about a 15-16% decline in cases for COVID. What does that translate into in terms of figures? Well, around about 150,000 cases in January through to February 2025. Now, we did see, interesting enough, when you look at documentations and publications, or certainly epidemiology data, we did see deaths rise by 28%. Now, again, this could be skewed slightly. This was around about 4,500 reports. This could be skewed lightly, and a lot of publications do identify that, yes, this is going over the wintertime, where we do see a surge, and we do see a surge both in poor outcome as well as cases. But also it reflected the fact that it noted that about 35% of countries are submitting data for cases, and only 10% are reporting deaths. So we're seeing more countries submitting cases and less submitting deaths. So overall, when they start to review all of this, they surmise that, yes, we're seeing a consistent circulation of COVID-19. It is starting to continue to decline, but we're seeing a reduced severity in the overall picture, which is hopefully something we'll see to continue that trend. In terms of the variants and the landscape, I mentioned it before, but just to mention the two again. So the XEC is a dominant variant, and there's a lot of that particular variant in circulation, but JN.1 is the one that's what's called a designated variant of interest. So that's one in which when you go onto certainly the WHO website, they'll have a list of these, and they'll regularly update in terms of looking at the global surveillance. In terms of then geographical patterns, it's always difficult to interpret this, again, as I've mentioned as well. I mean, what I would say, and this is really quite important, is that we're now reaching estimates of anything between 20 and 30 million deaths historically from COVID-19. So it is something that is still a challenge. And I don't want to dismiss it, because we have colleagues in places like Brazil where it still remains a hotspot. And South America historically has been hardest hit. So as much as I don't want to be frivolous about COVID-19, there are countries that still are working hard, and we all have cases that are still coming into the hospital. So it is something we still want to work hard to try and reduce and ideally minimize, if not eradicate, which I know is a huge challenge. And then what does this translate into long-term care for COVID? So post-COVID conditions, this affects around about 50% of survivors for up to 2 years. So again, not something to dismiss in terms of those challenges. And just to finally note as well, in terms of then variant tracking, the GIS-RS, I think it is, which is their monitoring system for WHO, I think it's around about 7 variants that they have on their list. So again, encourage you to have a look at that if this is your area of interest. And just to finally mention with COVID-19, I think with all the data that I've just mentioned there, it ranks as the 5th, I think it's the 5th deadliest pandemic in history. So we've gone through quite I'm sure we all feel it, we've gone through quite an event over the last 4 or 5 years. So overall, this is challenging. However, many reports do suggest, as I've mentioned, that we're seeing a reduced severity, which is good. But we see persistent circulation. So it further supports, I think, the theory that now we've transitioned out of the pandemic, which obviously that was noted in 2023, but many countries still deal with it as an endemic presence. So still something to monitor. So finally, there's always been viral dynamics, which include, importantly, common co-circulation of a wide range of viral pathogens. And our challenge is to better understand these dynamics. So as of March 2025, we've seen national surveillance showing that human metapneumovirus positivity rate and RSV positivity rate have been around about the same, around about 4 or 5%. And they've overlapped by about 5 weeks or so. Certainly here nationally and here in Canada, we're starting to see an overlap between these two pathogens. And certainly co-circulation is expected to increase as the years go on. And when we look at that dynamic, COVID-19 did kind of disrupt normal patterns. So what do I mean by that, and why have I mentioned human metapneumovirus? Well, human metapneumovirus seasonality is starting to revert to a more typical pattern now that we're coming out of the pandemic. Certainly something that we'd seen kind of pre-pandemic, I suppose. So what do I mean by that? Well, pre-pandemic, we would normally see human metapneumovirus peak certainly in the kind of the March time, and then certainly start to go through to early June, certainly in the Northern Hemisphere. And we would see a significant overlap between RSV, which would have been earlier, and human metapneumovirus. Pre-pandemic, we would have seen that that would have lasted for a considerable amount of time. So in other words, anything upwards of 11, 12, 13 weeks maybe, whereby you might have had that kind of overlap. Once we went through COVID, and I'll show some details of this, COVID effectively eradicated or certainly reduced the presence of other pathogens, and we were just detecting COVID-19 for a long period of time. And then as we're coming out of that post-pandemic period, we're starting to see things starting to adjust again. So this latest data shows that we're starting to see overlap. So this 5-week overlap between human metapneumovirus and RSV. And that, as trends go on, will start to then, as we've projected, start to then continue to increase in terms of that overlap. And so what does that mean in terms of when we look at RSV co-circulation patterns? What does that mean in terms of then global burden and clinical impact? Well, certainly when we look at meta-analysis, so in other words, when we look at all the data that we see, co-infections are associated with higher odds of pediatric intensive care unit admissions, which I think is to be expected. So what I mean by that is that we have a challenge with both the laboratory diagnostics, and again, I'll mention that later on, where there's lots of different bugs that might be circulating both within the environment and also within a patient, and also then the clinical interpretation. So a lot of these will present very similar. And so therefore, if you've got multiple positives, which one's the most important one, and how do we look at that? And so that has surveillance challenges. So when we have these kind of co-circulations and we have these bugs that do pop up, there are many countries, so for example, for human metapneumovirus, there are many countries that don't routinely test or publish human metapneumovirus. We're lucky enough to be one province and one country that does provide that kind of enhanced surveillance, but it does limit our global epidemiological understanding when there's lots of countries that don't do that. So it's really important to try to emphasize that it is something that we need to monitor. So overall, I would say in 2024, 2025, this season marks a potential return to a more extensive human metapneumovirus RSV co-circulation in periods that we'd certainly not seen since before the pandemic. So again, really important to kind of note these things. So we've talked about viral dynamics. We'll now talk about bacterial co-infection. So again, this is a challenge. So this is what we call kind of a pathogen soup, is kind of the way that I would describe it. So this is a mixture of all the different circulating pathogens roughly in the same environment. And as I've mentioned before, these bugs like influenza, RSV, SARS-CoV-2, human metapneumovirus, and even then bacterial respiratory infections like Mycoplasma. So this, of course, results in a more kind of diagnostic complexity in the laboratory, and laboratories do so well to support this because it's an ever-changing landscape. The clinical interpretation can also be challenging. Similar symptoms, as I've mentioned, present across different viruses and pathogens. And also, what do you do with multiple pathogens? You know, what do multiple positive pathogens mean? It might be something we often assume from an academic realm, that the clinical side of the service, when we get these positives, have got these well-trodden routes in terms of how we deal with a lot of these pathogens. And in a lot of ways we do. However, when we get multiple positives, there's still a challenge in terms of interpreting what these mean. Do we look at how we quantify the presence of these bugs? Do we look at quantification versus severity of disease? One of the things we've seen globally, and again, I don't want to go on a sidetrack, but I will mention this very quickly, and that is CT values. So CT values are something that are generated from real-time PCR. And there's some documentation and some discussion about how CT values might be able to be linked with severity of disease. Personally, I think that's a real challenge, but There's a lot of groups that are looking into this to see whether or not that is possible. So again, it's still work in progress in terms of how we look at multiple positives and also the presence of those and whether or not there's a link with severity of disease and, say, for example, quantification. So when we consider the complications of multiple infections, so we need to consider these bacterial in addition to viral pathogens. And so we've seen recent surges for Mycoplasma pneumoniae cases across many different countries. So we've seen rising detection of cases in Asia, Europe, and in North America, and I'll go into some detail in a few slides later. Often this complicates in terms of pediatric presentation and management because we're dealing with bacterial as well as viral. And then not to mention, of course, antimicrobial resistance. And I will mention this on a few occasions as well. When we have, or certainly there's concern when we have emerging secondary infections, how we deal with this appropriately in terms of treatment. So we need to really make sure that we optimize that treatment and make sure we provide antivirals and antibacterials in the best way possible. So when we're looking at kind of the epidemiology of Mycoplasma pneumoniae, so the global epidemiology of that over the last couple of years, and the reason I mention this is because we've seen, excuse me, a resurgence in this. And so what does this look like? So in terms of seasonality, because this is a bit of a surprise in terms of it's come out and we hadn't necessarily expected it because we've had a prolonged period of low incidence during COVID-19 of lots of different bugs, including Mycoplasma pneumoniae. And so this has re-emerged recently in 2023 in certain countries. And so there's some excellent publications around the emergence of Mycoplasma pneumoniae in many different European countries. And this then continued to increase in 2024. And we'd seen surges in North America, in Europe, especially in Denmark, Norway, Sweden, and France, as well as Asia. When we look at the typical trends for Mycoplasma, well, pre-pandemic, you were normally looking at anything between 3 and 7 years between different peaks and cycles. So there was a specific cycle, and it would often occur around about summer, late summer, certainly in the Northern Hemisphere, or early autumn, and then persists through into the wintertime, which is exactly what we've got now. In terms of age distribution for something like Mycoplasma pneumoniae, historically it's school-age kids and adolescents that would be most affected. But this recent surge, we've seen that it's also been affecting those from newborns to 4-year-olds, which we've seen emergency department visits and test positivities rise significantly in these age groups. So real concern in terms of how we want to kind of monitor this. So consequently, as a clinical impact, we've seen both an increase in mild, but also severe cases as well. And certainly more hospital administrations of what's called Mycoplasma pneumoniae associated pneumonia. I won't be saying that too often, and all the syndromes that are associated with that as well. So again, these have been observed. They've been observed as co-infections with other viral pathogens, and so therefore the presentation has been a little bit more complex and maybe in some cases a little bit more severe. So if we take this increase in infection, we also see concerns with antibiotic resistance. So it's kind of like, oh, crikey, okay, we don't want like a perfect storm here with regards to difficult to treat. And so one of the things is we monitor macrolide resistance. So macrolide resistance is a growing concern for Mycoplasma pneumoniae. When we look at it globally in terms of then as a macrolide resistant Mycoplasma pneumoniae rate, globally we see around about on average 28% resistance, which is like, I'd rather have that a lot lower, thank you very much. Now, when you look at it in different countries, absolutely, we're looking at a huge variation. So if I was to then say the Americas and the United States, albeit there's a little bit of a caveat there because they don't have a complete surveillance system in the US for Mycoplasma pneumoniae, but it's lower than 10%. So you're like, okay, then in Europe, it's about 5%, but then you look at Italy and it's around about 20%. Then you flip over to Japan and it's around about 50%. And then in China, we're looking at approximately 80% resistance to macrolide resistance to Mycoplasma pneumoniae. So you're like, okay, how can we certainly look at trying to mitigate this in the best ways possible? So what I would say is there's been increased awareness. So in other words, naturally, people are becoming more aware. And consequently now, we're looking at developing diagnostic strategies. So being those that are emphasizing where we've got people that are presenting and just making sure that these surveillance systems are keyed in with the development of tests that are then being produced. So CDC, ECDC, and PAHO are all closely monitoring both the trend, severity of disease, and also resistant patterns, which is great. So overall, in summary, certainly Mycoplasma pneumoniae, and hopefully I've been able to convince you that that was the reason I've mentioned this, has shown a marked global resurgence since 2023. So there's been high activity in children. This has been certainly a periodic epidemic peak. So in other words, we're seeing this rise with antibiotic resistance, unfortunately, particularly in Asia. And so therefore emphasizing obviously the importance of surveillance and resistance monitoring are critical for us to make sure we can provide an effective public health response to this. So again, certainly the last couple of years, this is one to be mindful of. So when we're talking about public health responses, what does this look like in terms of part of a coordinated effort? Vaccinations, vaccine impact. Yes, this has to be very, very important for all of us. So along with the challenges though, and I have the caveat, we've seen this now, we see this. So when we go onto social media, I take a deep breath, that's all I can say. So we'll move on quickly. So in terms of high level, so between around about 70 and 80%, upwards of 90% effectiveness for reducing severe hospitalizations for the range of preventable infections where we've got various different vaccines. Wow, isn't that fantastic? And as a consequence, that can be upwards of 25% reduction in hospitalizations. So you can see how there's a direct trend with how we can administer vaccines and how it has a proactive effect, not only in reducing severity within an individual, great, we don't want them to get ill, or we want them to have severe illness, but also then that reduction of them having to come into the hospital. So therefore it reduces the surge and the burden within the healthcare system. Lots of positive effects. So, however, some challenges as we know. So messaging, yes. So influenza is a good example. I'm going to pick on a few others as well, which you're probably going to anticipate, but influenza is an example. So people kind of go, oh, well, it's moderately effective in terms of then as a vaccine. And so therefore, I might take it, I might not take it, but it's still something that's highly recommended. And so therefore, it's certainly something that I would emphasize as you're going into the winter, get your flu vaccine. Really, really important. And I know that just as a side note as well, anecdotally, I know the people that that genuinely have the flu that then go and get their flu vaccine. So the people that then say, and again, I don't want to criticize people, but I've seen them within my province where they'll go, yeah, I've had the flu, a little bit of a runny nose, but it wasn't too bad. I'm like, that probably wasn't the flu. Whereas when it's somebody who is like, wow, I could hardly move, it was a systemic kind of lethargy that you get, then you're like, this sounds kind of like you had the flu. And then they say, I never want that again. And so therefore they're like, I'm going to get my vaccine. So you're like, excellent. So that's the way that I'd want to encourage, to then say, I don't want people to go through, get the flu. And so you do tend to find that obviously those that have certainly then know how important the vaccine is. So listen to those people. So if you haven't had the flu, great, but get your vaccine. And so there are various different reasons why we have then vaccine lethargy and hesitation as well. So we have coverage gaps, whether that be equity of care within low and middle income countries or within then comparison to high income countries. So a good example is less than 35% RSV vaccine uptake in older adults. Certainly when the data shows that it's been highly effective in the above 65s and provides long-lasting protection over many years. So as a slight sidetrack, this is the most recent paper discussing the effectiveness of the RSV vaccine. And so, by the way, I don't have any affiliation or conflict of interest in any pharma companies, sorry, should I say, in terms of, or any kind of research companies or any groups. But this is a paper I would encourage you just to have a look at it and read it. This is one of 3 that have been produced to show the effectiveness of this particular RSV vaccine, which historically has been a challenge. And when I mean a challenge as in providing long-lasting immunity. And these papers have shown that actually over 2, 3, even 4 years, that we're seeing still maintaining protective levels of RSV above the 65s. And this is in addition to not reducing significantly the effect of the flu vaccine or others as well. So again, I would encourage people, have a look yourself. So this is one that just came out in April. So brand new, hot off the press. So I encourage people to have a look at that if you get the time. So moving on, so in terms of other things, so hospital having a robust preparedness strategy. So in other words, how we start to look at these public health responses, making sure that they are prepared for surge capacity. Surprise, surprise, we seem to be in hospitals like every winter going, oh, we've got a surge. And it's like, yes, that happened last year. And so, like, let's be better prepared if we can. Sometimes it seems to come as a bit of a surprise to administrators, but I could show them 20 years worth of data and more that winter equals surge. But anyway, that's something that we need to be better prepared for. Antivirals, antibacterial stockpiles, in other words, making sure we have that available, but we're treating appropriately. So we make sure that we give the right thing. So just being mindful of AMR. Surveillance advances. So making sure WHO, PAHO, they're providing real-time now tracking systems. So influenza-like illnesses and severe respiratory infection tracking over more than 30 countries, which is fantastic. So this real-time tracking helps us then be as adaptable as we can be to responses. We're starting to see developments now with surveillance for wastewater monitoring. So there was a big surge with regards then looking at COVID-19 in wastewater. Some challenges in terms of how we interpret that, but then what does that mean in terms of monitoring other pathogens? And is it going to be useful for other pathogens? Let's see. In other words, let's look at the data and let's explore that and let's discuss it as a community and then see whether or not there's a one world approach there. So in other words, integrating human, animal and environmental collaborative surveillance. So in other words, linking in what is still pretty much in a lot of ways silo networking. So how we look at this from a one world health perspective. And then finally, I touched upon it with the COVID variants, genomic sequencing. So rapid strain identification of bugs such as influenza and RSV. So knowing what subtypes are being circulating. So again, I'll touch upon this in the Southern Hemisphere, how we want to try and identify what the subtypes are, because it could drive preventative medicine and vaccines for the Northern Hemisphere. Again, though, there are challenges in terms of regional variations. I touched upon before, half of the countries in Europe said that they'd had increased influenza-like illness baseline measures, but then the other half didn't. So what does that mean and how do we interpret that? Canada and Mexico had epidemic influenza levels, but I mentioned the Caribbean had RSV declining. North America had peaks. And again, as mentioned before, we're getting distribution of different flu A subtypes, the H1N1 2009, and also the season flu. So again, this emphasizes how surveillance is so very important. So then moving on in terms of then emerging threats. So how does this data drive our understanding of emerging threats? So we have predictable seasonal viral surges. So I mocked a little bit in terms of then, in general, we have surges, but there is nuances to that. So in other words, I did mention, of course, things like, for example, the human metapneumovirus co-circulation with RSV. We do see these changing trends, and I'll show you some local data to show that it actually sometimes is difficult to predict that as well. So that co-circulation and the changes in that co-circulation can be a challenge, but certainly that is something that we want to monitor in terms of emerging threats. So in other words, co-circulation of pathogens. Mycoplasma pneumonia, I mentioned before. So in other words, looking at the complications of secondary bacterial infection or primary bacterial infection with maybe a secondary viral infection, depends how it presents as well. Looking at the distribution of different subtypes of avian flu. So I've mentioned some of them, but there's also others as well. So H5N1, H9N2 and H10N3. So all these different subtypes of hemagglutinin and neuraminidase that can change around these genetic reassortments are keeping us on our toes. So in other words, what does that look like in terms of that direct link to, for example, poultry, and how we look at human-human transmission from animal groups? So really important to look at that as well. We still have to deal with COVID-19. So that is circulating. We do see fluctuation in case numbers, but again, as I've mentioned, we're starting to see that decline, but we still want to monitor that in terms of then we recognize that that is still endemic or is endemic in many countries. And then I briefly want to mention, so other threats. This is not directly related to respiratory, but climate change, and I'll touch upon it as well, does change a few things. So dengue fever. So in my clinical work, there is certain instances whereby we look at travel history as being quite important. And so as we start to see climate change, we start to see then different risks in different parts of the country. And so malaria, for example, and I know that some people on here may be from Florida, possibly. I'm probably going to get a wry smile from somebody. Yes, I see there. So I'm not picking on Florida, but a really interesting case in terms of we had a couple of malaria cases that were published, but these were people that hadn't traveled outside of Florida. And so that is really interesting, because then we start to look at, okay, then is there starting to be a climate change? Because that's not something historically we would have seen if somebody came back here and presented with what would have been malaria-like symptoms, but they just traveled to Florida. And I'm not putting people off Florida, of course, by the way, lovely, lovely state. But a case of then saying it wouldn't have been necessarily on our differential. So again, we want to try and monitor these things. Measles, that is certainly something, again, that we want to see. So when we talk about emerging threats, that's something as a virus that we want to try and monitor. Vaccination, highly effective. And so therefore we want to try and encourage that proactive response as much as possible. And then monkeypox. So all of these things are kind of things to be mindful of. However, what I would say is that certainly the top of the tree is still influenza virus. So especially those with kind of that zoonotic potential. So these remain of a high concern for kind of rapid emergence and global spread. So we still kind of monitor that as well. So I just wanted to give a flavor of, it's just super busy, isn't it? With lots of things that are circulating. So just how important you all are in terms of then the various different things that you do. So how do we prepare for this then in terms of then prepared strategy? Well, we look at surveillance and monitoring. So that's so very, very important. We want to establish, and equally important, maintain robust global surveillance. So we've done such a good job with COVID-19. We want to try and strengthen that and maintain that. We want to strengthen laboratory capacity. So again, we don't want to burn out our laboratory colleagues in terms of then they've done such a wonderful job with academic services. There was a whole host of, it takes a village, absolutely, in terms of then a COVID-19 response. But how do we maintain that in terms of then saying we shouldn't switch off now to then say, oh, well, we've done that now, there shouldn't be an issue with anything else. I've just given you some examples of where we need to be careful with that. Vaccine development, we touched upon in terms of then making sure that we can invest in development of vaccines, and just making sure we can improve vaccine manufacture capacity. And that then leads on to, importantly, making sure that we've got equity, or ensuring equitable access to vaccines across the entire world. We all live on the same planet, so it's just a case of saying, and as we know, I've mentioned this many, many times before, pathogens don't have passports. So if COVID has taught us anything, and COVID shouldn't have taught us, because there's plenty of other bugs out there as well that don't recognize international borders. And so therefore we need to have a global response. So that's really, really important. And also, importantly, promoting vaccines, just making sure that we have a due diligence to provide to the public as experts to then provide the information that they understand. So in other words, let's not be too overcomplicated about it. So let's not be too highbrow. Try and provide information that the public understand so they can interpret it in the best way possible to know that vaccines are safe and they're an excellent way of providing preventative medicine. So those are the kind of things we want to do. So when we have established vaccines, so further kind of infection prevention controls. So in other words, when we've got them established, unfortunately, so if we can't necessarily prevent the spread, but for example, we've already got it established, what do we do? Well, infection prevention and control. So in other words, implementing and maintaining effective prevention control is really important. So again, public awareness, making the public aware of good respiratory hygiene practice. And I know that that is very difficult right now, certainly with the kind of the lethargy, and I understand, coming out of COVID-19 in terms of emphasizing hand washing, even emphasizing in certain settings here, even in the hospital here, mask wearing where it's appropriate, of course, and also social distancing where it's appropriate. So just making sure that we can monitor these things. And there's a balance to that in terms of then making sure that people don't completely switch off. And so linking with that public engagement, this can be difficult, absolutely. So there is kind of like, we're looking at things like what's called risk communication and community engagement. So I could use examples in the past. So the Wakefield et al. Paper, again, I won't dwell on that, but that was the MMR linked with autism. And again, did we do a great job in terms of responding quickly to that? It always seems like, and certainly post-COVID as well, that in terms of social media, do we do a really good response compared to lots of other social media and chatter and noise out there? I think we could probably do better maybe. But anyway, not a criticism, because I understand it is complicated, but certainly areas we want to focus on. And finally, system learning. my gosh. So yes, international collaborations, making sure that we can strengthen. So my colleagues to the south, I want to make sure I work with them contrary to maybe what the political landscape looks like. I want to work with my colleagues south of the border as much as possible. So, and I want to continue to do that. So that I will do that unabated. And I would encourage everybody around the world to then collaborate, work together, communicate. When you go to conferences, speak to people, you know, reach out to me, reach out to other people that are on this talk today, and just find out what they're doing. And you'll always find people with expertise in something that then can just fill that gap, and then we can get that better understanding. So again, system learning. Let's not forget. I've actually been around long enough, and I had that wonderful introduction to see a number of different instances play out. And it's surprising, even just after a few years, when you then engage into a system, how they tend to forget sometimes what we did last time and the best things to do, and maybe to avoid the worst things. So really, really important to be able to focus on that. So key challenges overall then, as I mentioned, and again, I don't want to dwell on this too much, but it's about then saying, well, okay, then understanding pathogen complexity and co-circulation, just making sure we've got that in our heads. Yes, absolutely. Vaccine coverage and equity, just making sure we've got that available, but we can just then provide that across borders. So in other words, we make sure that the people that need it get it, and that's important. Antimicrobial resistance. So again, just focusing on making sure that we provide appropriate treatment. So again, simple things like viral infection, no antibacterials, please. So it's like they're quite straightforward things, but you'd be surprised in terms of how we still hear people that might have a viral infection and then antibiotic is maybe provided. So again, admitted it's complicated because there could be lots of nuances occurring, but we want to try and just make sure we've got appropriate stewardship. The data surveillance and sharing. So in other words, just making sure we have active surveillance, as quick as rapid response surveillance as we can, which is really important. Healthcare capacity systems. So how does that drive healthcare capacity systems? So making sure that we have then, yes, we're going to have a busy winter. Have we got everything ready for a busy winter? Just making sure that we are, and again, this is something that I may have not touched upon, economic and social impacts. Sometimes I find we're not, or we could do better at making sure we provide the true health economics. So I can still, even within my hospital, because it's quite siloed, struggle to get the true health economic impact of the intervention of a vaccine or the intervention of a rapid test being applied. And overall, because of the silo economic kind of approach to various things, if you were to integrate all of that, you could rationalize and see significant savings with regards to then rapid introduction of tests in certain settings or an implementation of a certain process. So it's important to show that we can provide that data, and so maybe just trying to improve that that social and economic impact. Again, it's something maybe we shy away from a little bit because it shouldn't be about the money, but unfortunately the world is driven that way, and so we need to do that. So we need to then say, adding this, believe it or not, moving from culture to a rapid molecular test is going to save you money, even though the rapid molecular test costs more than just plating something out. I've heard it for decades. And so it's about how we better do that and how we better move that on. And then finally, climate change. I've touched upon it. So in other words, and I've mentioned our lovely state of Florida in terms of an example with malaria, but it's a case of then saying, well, we're going to see other things as well. So we see extended rhino entro throughout the whole year. I remember decades ago whereby rhinovirus is kind of like a common cold would have been associated seasonality over the winter times, and you wouldn't see an awful lot of it over the summer. Now we're starting to see, actually, we see a presence of that throughout the entire year. So good examples about how extreme weathers can impact on spread, but also extreme weathers, how can then disrupt healthcare systems as well as exacerbating respiratory illness. So just being aware of that as well. So I did a very quick skip through that. And so I'm going to very quickly go through some, because I'm conscious of time, some of the quick data from Alberta. And so just focusing on that. So in Alberta, we have, I mentioned, a respiratory workup. And so this is a list of the different pathogens that we perform here. So lots of them there. I won't go through them in a huge amount of detail, but this is what we regularly do for symptomatic patients. Again, I'm not going to bore you with the details of this, but certainly to say that Alberta is, just into context for those who don't know, Alberta is around about 3 times the landmass of the United Kingdom. And just to put it into context as well, we have one single hospital clinical system for the whole province, and we have one single laboratory system as well. And so what that means is when I show you some data following on, we've got some really granular, accurate data for the entire province. Yes, we have just shy of maybe 4.5 million, but we have a really accurate sense of what that looks like. And so this is kind of a schematic that I oversee the respiratory infections for the province, a schematic of what we do in terms of then a cascade for community and hospital patients. And now we prioritize and make sure that we can get the appropriate tests. So what does normal look like? So this is brand new. So in other words, this is hot off the press in terms of showing you some of the data that I work with. So the top graph shows the total number of cases for a range of different viral pathogens. With the color key you can see at the bottom there. The bottom graph shows the percentage positivity rate. So that is on the right-hand side, you'll see on that bottom graph. And then the gray bar you see on that bottom graph is the total number of tests that we perform. And so we can get a sense of then the distribution of all of this. So to highlight a few interesting trends here, you can see that although our testing was high in 2020, 2021, there might have been many factors that influenced this, but we saw an absence of pretty much all pathogens. So you'll see that there's kind of like a grey bar there in that bottom graph, and like a purple line, which is our enterorhinovirus, but pretty much nothing else. So I'm sure that probably lots of people have seen this before, but we actively saw this in terms of a blip. Before then, we started to see that recovery again back into what would be considered to be normal. So taking kind of like a little bit more of a focus. So when we start looking at respiratory pathogens throughout any given year, and ideally multiple years, of course, and then what impact COVID-19 had on its arrival in early 2020. The arrow that you can see there in red depicts roughly when WHO had signaled the start of the pandemic. It was around about the same time that we saw our first case here in Alberta as well. So you can see kind of a significant impact there. And then exploring this a little bit further, you can see that there was a dramatic drop. So the blue arrow there with the blue line is flu A. And you can see that had a dramatic drop amongst others as well. So I'd kind of put in another year there just to see that we see cyclic trends in all of this. And we even though we saw a presence of enterorhino throughout the pandemic, again, much less than what we would have seen normally. So certainly at that time, we were starting to interpret this real-time data coming off going, well, I'll tell you what, COVID does not play well with others. But admittedly, there's lots of different reasons why that might have been the case as well. So quickly to put it into context, this is COVID testing as well. So the blue arrow there is when we started to do COVID testing. And so you can see that this is on top of respiratory testing. So the previous graph I showed you that we are doing anything that was maybe possibly 6,000 tests a week in terms of respiratory in the highest times within the province. This is showing that we started to do a couple of hundred COVID tests a day. That was peaking to over 20,000 tests a day within the province. So an extraordinary response at the same time as doing respiratory testing. So utility is really important for us. So I wanted just to show you again with some data here with regards to 2 different years. And so how do we understand the spread of infection? So you can see that the blue arrow at the top there, we're looking at a flu A outbreak. And so certainly you can see there that we've had a significant outbreak or a significant season in terms of flu A. And then we look at 2024, 2025, we're seeing that the number of cases is much more prolonged. So the season is much more spread out. So again, it's about then saying this is real-time data that's coming off. So this is literally a few days old that we're seeing kind of like, well, it's important to monitor what that means and what impact that has. And then that lower graph, you can see that there's a gray arrow there. So some of the things we're trying to do for utility is just making sure that we're doing appropriate tests at the appropriate time. So in the summer months, we're restricting where there's low incidence of certain viral pathogens, then we're restricting the number of tests that are available. So if we're not seeing a huge circulation of flu or RSV, then we're reducing the availability of the flu RSV test within the summer months. So generally that would be within around about May, late May, early June through to September. And so you can see that is the number of tests that have dropped there. And so again, that is something that you can see here, where I've gone and taken a number of years. And again, system memory. So I talk about system memory being important. Well, it kind of have a flip in terms of disadvantage, because we had pre-pandemic fairly cyclic kind of low levels of respiratory testing. We then have the blue dot, which is then the start of our pandemic. I showed you the separate COVID testing, but this is then the separate respiratory testing. So you can see for a number of years then people are much more aware of respiratory testing, and so therefore the numbers and the utility have gone up hugely. So it's about how we can combat that and then say, well, okay, then is all that testing actually necessary? And so what are the ways in which we can start to then bring that down? And I'm sure there's many countries and many areas within countries that have probably seen similar trends as well. So we're monitoring this real time, and it's about how we can impact that. So I want to give a very quick example. I am conscious of time. I want to give a very quick example on, again, different ways we can utilize this. So this is one approach in which we can look at the distribution of cases and disease for age. So this is for the last 7 years for below fives for RSV. And so you can see here that we've got a significant peak height in 23-24, but it is lower than 22-23 for under fives. And the 23-24 is probably more akin to what we'd see in 2021 and 2022. And what's interesting as well is we can see that post-pandemic, there's much more of a presence of RSV compared to pre-pandemic. So in other words, we're seeing this consistency. And so therefore, really important that we monitor this. And obviously RSV equals children is often something that we would associate with. And then the flip of that is then when we look at those aged between 5 and 17, you can hardly see any RSV at all. But then moving on to then the older age brackets, you can see that there is a presence. And it's a very similar trend that we'd seen below fives, albeit proportions are much smaller, whereby we have seen a significant presence in the last 2 years, but slightly less this year compared to the previous year, but certainly more than we'd seen pre-pandemic. So again, it's what this means. Yes, we're testing more. So are we testing more and therefore finding more? Possibly. So again, something really interesting for us to kind of monitor as we go through. So just quickly then, in terms of then some other examples, we had RSV as an example. Flu is another example. So in other words, we can then start to overlay both subtypes and also then seasons. So these graphs show, the left-hand graph show subtypes. So we can start to see, actually, is there a single subtype that's circulating? Is there multiple subtypes that are circulating? Do we see ones appearing rather than others? So the graphs that you see there, the blue is the H3N2, and then the green that's following on is flu B. So in other words, it's about then saying how we understand that. And the dark red there, or pink, that you can see in that graph is the H1N1. And so again, it's about just recognizing what that means within the season. The graph on the right-hand side then starts to overlay different years. So we can see with that grey one, that grey season, so the grey line for that season, had a sharp increase, but it was fairly early in that particular year. But it then declined quite quickly as well. So the season lasted about 4 weeks. Whereas there was a season with that blue line that started, could have been at least a month later, looking at the graph there, and then extended on and lasted for several weeks longer. So it's important for us to then use the data and then say, what does this mean in terms of predictive models? So is this useful? Can we use this to predict future trends? And again, I touched upon, we can break this down. It is a challenge, though, I have to say, in terms of then saying, well, yes, but do we see predictive models? Well, in 23-24, we saw H1N1. 22-23, we saw H3N2. Prior to the pandemic, we saw a flu B circulating with a little smattering of H1N1 and a little bit of H3N2 as well. So there was lots to go on there, but is there a pattern that we can see? Not necessarily. So again, it's important we have the data, but does it provide us with certain valuable information? And so when we look at it, we can then say, well, okay, then what does this mean for the particular things that I mentioned, which was hospitalizations, ICU, and deaths? So we want to monitor that, but I wanted to point out for a particular year, we saw that flu B rise. So in other words, you can see a significant increase in flu B cases. And that resulted in a significant number of cases for that particular year compared to others. What I would say is that, yes, we did see a bit of a higher than average hospitalization rate, but fairly normal levels of ICU admissions and a slightly higher death rate. But was it significant in terms of then any changes? It wasn't statistically significant, but what we did see is that flu B rise. So what does that mean then in terms of then, well, how could we have predicted that? it's a challenge, as I mentioned. So when we look at the last 10 years or so, when we look at specific things like case counts and death rates in terms of then any specific patterns, there's not necessarily a discernible pattern there. So, and again, I've shown the graph before to then say, well, we've seen single spreads of certain subtypes, and we've seen heterogeneous spread of certain subtypes as well. So again, a bit of a challenge in terms of, is there any pattern there? We can't quite see it. And again, when we look at it from hospitalizations, ICUs, and deaths, not really a pattern there. So I'm not going to dwell over that to then be like, let's explore this in detail. But suffice to say, trust me, I've looked at it in detail. We haven't really seen a pattern. I'd love to see a pattern, but we haven't seen a pattern. And so one of the things I would want to point out, Southern Hemisphere, I did say I would mention this briefly. I'm coming to the final few slides, so it's okay. So Southern Hemisphere, it's really important I wanted to mention the Southern Hemisphere because they do a huge amount of fantastic work. And so I wanted to display a couple of slides here. You can see the slide on the left, which is showing the different surges for different years. And then the slide on the right is then showing different subtypes. And so the theme of this is what I wanted to present, is to then say, well, okay, then for 2023, Southern Hemisphere went, right, okay, this is the surveillance we have. We're starting to see, we don't normally see flu B, but we're seeing 40% flu B within our particular season. And that's like, oh, that's really interesting. So, okay, then what does that mean for us? So normally for us in the Northern Hemisphere, we might see anything from 0 to maybe 10%. 8-10%. Certainly in the province of Alberta, we might see no flu B. We might see maybe 5% flu B. When we then look at our 23-24 winter season, compare it to their 23 winter season, so in other words, the winter following theirs, we saw a 30%, over 30% flu B, which I showed you with the numbers previously. So yes, there is some correlation there to then say how important it is for the Southern Hemisphere to then drive the information we have for the Northern Hemisphere. So there's a slight one there I wanted to pull off this. There's a slight tangent. This is just recently came off a few days back, just to show that you're getting a fresh presentation, of course, which is always important. And that is that PAHO do these. So these are kind of the trends. And so we will receive these on a regular basis. They're just starting their winter. So obviously the trends are just starting, but they're starting to provide us with summaries. So in other words, it's about then case then saying, okay, then they're seeing H1N1 and it's the 2009 with a bit of flu B maybe. So it's like, thank you very much. Good luck with your winter season. We'll see you after your winter season and we'll see what impact and what interpretation we can get from that to then prepare for our winter. So again, go into these things. They're a fantastic resource that you're able to then start to read through and work through. And then just coming to the end of the viral things before I touch upon some of the mycoplasma, I don't want to go into any great detail, but it's just suffice to say that one of the other things we want to look about is the emergence of multiple different or possible multiple different influenza strains. So these constantly go through genetic change, and they go through genetic change while circulating through a lot of wild and domestic bird populations. They can go through various different settings in terms of different animals, foxes, minks, dogs, cats, sea lions, but to name a few. And so it's really important then for us to monitor this. And I touched upon this before to then say, well, this is what we monitor, because our concern is that there's going to be one that effectively then transmits in a mammalian species and then transmits highly between different humans. And because we don't normally see these because they're in a different population, that's what the severity is. So in other words, they severely affect us because our immune system hasn't seen these before. And so these are fairly new to us. And so severity to an unfamiliar immune system is quite commonplace. So again, something we are monitoring carefully, and you'll see this in terms of then research and news consistently as time goes on. So that's the summary. Hopefully I've been able to show you just how effective clinical diagnostic services are and how comprehensive surveillance systems need to be to kind of help. And then I'm just going to touch upon the last few slides, which is the Mycoplasma pneumoniae. So forgive me for going on a little bit, but it was comprehensive in terms of global and also local data as well. And so Mycoplasma pneumoniae, I don't want to go into huge detail, but I don't want to assume everybody knows Mycoplasma pneumoniae. So what is it? So it's a gram-negative. They call it paleomorphic. So what do we mean by that? Well, that means it can just barely vary in shape and size. So a fantastic little bug. It is the smallest organism we have that can self-replicate. How funky is that? It doesn't actually have genes as well that encode a cell wall. So what that means is that it kind of lives a parasitic or kind of a saprophytic existence, but it also, because it doesn't have a cell wall, is resistant to cell wall antibiotics. So something like vancomycin, completely useless. So really important to know kind of these key features, but a fascinating little bug. And then in terms of them, what it is, so global surge, we've seen this global surge. So I would encourage people to kind of look at the publications out there. I touched upon the spread of infection over the last couple of years, and certainly the surge that we have seen over time. And there's plenty of international publications there. So key into those publications, have a look at the trends. It's really interesting because we don't see this every year. So in other words, I think this is a real active, interesting area because we don't see it that often. So really something we want to explore in detail. And that's no different in terms of close to home. So when we look at Canada, we're seeing that again, we're seeing this specific surge, no different from the rest of the world. And then if I look at Alberta, again, we're seeing that same surge. So in other words, we're seeing it in younger kiddos, certainly ages 0 to 1 and 2 to 4. And we're seeing that emergence across Canada. So Alberta is the same as Canada, as the same as the rest of the world. And then as a summary slide to all of that, you can see that the left-hand table is a publication from a few years back on Mycoplasma pneumoniae, and over a couple of months, some of the cases that they saw that they wouldn't normally see. And so really good publication there. And then this is, again, live data from a day ago in terms of then just looking at the surge of cases that we're seeing in Alberta. So you can see the respiratory tests that we do. So that's the several thousand that we might do per month. And then the number of positives. The number of positives might not seem a huge amount, but we were normally trending with 1 or 2 cases a month. And then we're regularly seeing, certainly over the winter months, over 90 cases. So in a population like ours, that went from virtually 0 positivity rate to 1.5 positivity rate. So something that was really quite significant. So really tying it all up, my final 2 slides. What does this mean in terms of development? Vaccine development, absolutely important. So things like, for example, adhesion proteins. So this particular paper looking at adhesion proteins and also fusion proteins. So in other words, they're combining different adhesion proteins and looking at impacts in terms of then how it reduces colonization, certainly in animal studies, which is really important. Diagnostic advances. So looking at ways in which we can really effectively identify through rapid detection Mycoplasma pneumoniae. It's a real pain to grow. So molecular is the gold standard, is all I could say there. We've got treatment evaluation. So again, looking at macrolide resistance. So in other words, how can we look at treatment evaluations and making sure we can utilize macrolides and other treatments effectively. Epidemiological trends, of course. So in other words, looking to make sure that we can monitor this, making sure that we can exactly know what is going on, both within our regions, countries, and also globally as well. And then finally, antimicrobial resistance, how important that is. So again, it's about surveillance, about monitoring. I showed you some of those stats, which were kind of eek. So it's a case of just making sure that we can minimize, reduce, effectively manage the resistance rate that is developing within Mycoplasma pneumoniae for macrolides. So that gives me to my thank you very much. I do apologize I ran over slightly, but hopefully you have seen through my summary that it's important to continue to support clinical diagnostics, driving effective epidemiology, and continuing to value collaborative research, which is so very important. And then the last thing I want to do is just to say I'd like to thank all my colleagues, both clinical, technical, and academic, and those that work within the healthcare throughout the entire world, certainly for ongoing efforts in terms of improving diagnosis, treatments, monitoring, certainly for a wide range of infections, and especially after the Herculean efforts of the COVID-19 pandemic. And I couldn't do my job without everybody else. It takes a village. So this is how I relax with my bike ride to work. So thank you very much for your attention.
Thank you, Matt. I appreciate the comprehensive journey through this topic. We have very limited time, so I'm going to sort of summarize the question into 4 or 5 little topics, and then you have to give me quick answers because we
I will
stop.
try.
Okay. So the first one I'll start with RSV. If you already have RSV vaccine 60 to 80% effective, Hasn't it been adopted in other countries? For example, you said we have a China is a hotbed for RSV. Haven't they adopted the vaccine schedule there?
Yeah, so I don't know where we're at. So these vaccines are fairly new. So in other words,
Okay.
the effective of that, certainly I think it's the GSK that have that most recent
Okay.
vaccine. So it's fairly new. So I think countries are still looking at the data. There are certain countries that have then ensured that they do have it available, and in some ways they have it available with regards to not within their schedule, but they have it available for people as a fee paying vaccine. So I think countries are just monitoring right now, but certainly the data as I presented with that screenshot of the paper, highly
Mm.
effective. So one that would definitely be one to consider.
Okay. Do you mind unsharing so we'll have the group on share?
Sure.
Thank you. So the other quickly I want to touch upon is that adult vaccination, right?
Yeah.
You briefly talked about it. I know CDC has a schedule, and I couldn't find a real schedule for Canada, but I think I like you to maybe make a comment that um, it is very critical. I'm a very proponent of adult vaccination. It's not quite recognized by many, many people and the many, many countries. Maybe to our audience benefit, we can say something about that.
Yeah, so I think certainly we see that there is a huge variation in terms of then vaccine schedules and vaccine availability. I touched upon the equity of kind of vaccine availability. I think it's really important that maybe the community starts to look at ways in which we can use technology to make people aware of where the vaccines are and what vaccine schedules do exist. Because we travel so much, why not consider an app and a vaccine app? Somebody, so it's
Uh,
certainly, I mentioned that because it's something I'm looking into. So, whereby you can just basically say, I'm traveling to this country, and you obviously give the origin of where you are with the assumption that maybe you've gone through a vaccination schedule. It'll then provide you with a gap analysis. So, and that could be for travel related, or it could be for if you're relocating to a different country. So, yes, there's difference. Just as a caveat, very quickly, reason why you couldn't find a Canadian one is because it's per province. So each
mm,
will have a vaccination schedule for its particular province, which has its own challenges. So again, do we want to look at standardization? Again, that's difficult because I showed that there's variation of disease and variation of exposure and risk. And so therefore it might need to be reflected within the vaccine schedule, but certainly there should be a lot of commonality there and it should be encouraged. Hopefully that was
yeah.
the message I provided in my presentation. Immunizations, definitely.
Okay. All right. So I want to jump to Africa because I have a comment as well as a question. So when you talk about Southern Hemisphere, and I know PAHO takes care of the South America and the Caribbeans and the Central America, and Australia has a pretty good surveillance. What's happening in the continent of Africa?
Yeah, so it's something that I've not got a huge amount of experience in myself because I focused on a lot of South America. I certainly did when I was in the UK and now here, which is a bit easier. But the WHO do a huge amount of effort and a huge amount of work within Africa. And certainly I would say that would be where I would point kind of the resources to go to in terms of them where this is. I know the UK and I know a lot of European countries have collaborative kind of units and collaborative efforts with lots of colleagues and countries within Africa. But yeah, I agree. I think that there's still a lot of work to do in terms of
Okay.
we want to increase, certainly level the playing fields between high income and high resource and
Yeah.
middle countries.
Yeah.
That absolutely
Yeah.
needs.
Yeah, thank you. So that will probably answer the question of the bless. Is mycoplasma prevalent in Africa? And my guess is that we don't know because we probably lack the surveillance, right?
Absolutely spot on. And I think that is the challenges we have. I work with a number
Mm,
of different countries in South America. Bolivia and Guatemala are two countries I
mm,
work closely with. And the same
mm,
problems there in terms of you need to have an effective surveillance to then drive effective responses.
mm,
And so you tend to find politically it's a challenge sometimes to then say, can we have something in place, please, when you don't have the data to show it? But then you need the
mm,
money to have the surveillance system to show the data. So it's a challenging one for sure, but certainly something we want to keep to work at. But yes, absolutely. I would say that limited surveillance is probably driving limited data.
Okay, thank you. So the other, I want to cover two more areas. One is the SARS-CoV-2 variant. Do we know where are the new variants appearing? Is there a geographical affiliation to the appearance of the new variants? A quick answer.
Yeah, I think that's an excellent question. I think a lot of this is biased towards where we've got enhanced surveillance systems in place. And so it's the reason why they started to designate with the numbers and letters rather than the locations. Only because, again, that was biased in terms of then the UK strain or the Florida strain or whatever it might have been. It's a case then saying, well, they probably had enhanced surveillance systems that just found it. Doesn't mean to say that that's where it originated from. So
Okay.
I think it's quite difficult to then say, and I wouldn't want to then say, well, it's originated from this particular place, because guess what? They've got next generation sequencing in place. So it's like, well, surprise, surprise.
Exactly. No, very good answer. So they okay. So and the other quick question is how quickly RSV genome evolves? Because I can remember, is it do we have a lot of serotypes that making it challenging?
Yeah, that's a great question as well. So we have RSV A and B. We tend to find that they don't change a huge amount. So in
Ah,
we tend to find, but this is research that we're currently doing now. So in other
mm,
words, well, I say we are in this province, but I'm sure lots of other people are as
mm,
well. We
mm.
don't tend to find it has the genetic changes and mutations that are akin to something like influenza. But we do know that it does have the ability to obviously change. So I think that's active research. So it'll be watch this space, and I'm sure lots of people around the world
Yeah.
will present some interesting data in the future.
Yeah, it's a very good one, especially if only have serotypes, you would think that vaccine would have worked much faster. But it is, RSV, I cannot emphasize enough that it is an issue not just in children, but adults above 65. And I got my vaccine. I am like, no,
Well done.
I'm a walking body of vaccine antibodies. Okay, so one, two last one. I'm watching the time. Uh, a macrolide, I am so shocked because it's a last resort antibiotics. And if you have getting 80% resistance in some countries, that is disastrous for the whole world.
It's a challenge. It certainly is. So
Wow.
yeah, that for me is when we're talking in places like Japan where it's over 50%. I mean, it's significant in a number of countries, even in Europe where we've got low levels, but in Italy they were reporting over 20%. This then seeds it. So that just simply emphasizes the need for development of more antimicrobials
Yeah.
as being important, but also then effective stewardship. So it's
Yeah.
development of new compounds and effective use of what we already have.
Yeah.
Absolutely vital.
An anecdote for you, when I started in cystic fibrosis, many CF doctors were using macrolide without approval, but because there were cases where it really helped in Japan that triggered the massive CF treatment with macrolide. But okay, let's go to uh, um, when do you, this is a question that I always address people with that you start with a viral infection. At some point, you completely clear it, or you transition to a bacterial co-infection. What is the time frame? Again, it's a very subjective question before you would consider an antibiotic treatment.
Wow, there's a question. So I could have an out here and be like, well, it depends on the patient, the presentation, and the progression of disease. But what I would say is that certainly, so for something like Mycoplasma pneumoniae, it is something that we would want to try and not encourage to treat unless it is severe enough. So I want to
Mm,
put that out there in terms of then saying it's not something that we would then rapidly then perform treatment. However, if there is something, for example, like a secondary bacterial infection like a Streptococcus pneumoniae. What we want to be doing in those scenarios, because we know that that is closely associated with severe outcome in terms of pneumonia, we want to try and then look at an individual that maybe has had a viral infection. Maybe this is over seasonal winter. So in other words, we know that that's going to be commonplace anyway. And then they're in a high risk population. So in other words, they might be very young or very old, and then they develop or have the presence of strep pneumoniae. In those instances, with those risk factors, you would want to then absolutely start to ensure that you would maybe even start some kind of empiric therapy before then drilling down and then focusing on a specific treatment once you better understand the dynamics of the bugs. But all about risk factors of patients, making sure we can maximize positive outcome, and depending on what the bug is.
Okay, thank you. Fantastic. Good answer. So I want to end with the comment, and the comment is that climate change, right? Before I do that, anyone has any specific questions for Dr. Diggle? His information is online. You can just Google his name, and his email ID will come, and you can always write to him. So the comment I have about the climate change is, it's clearly recognized even with the dengue that the climate change is pushing the mosquito population further and further north from where it used to be, and that comes along with that comes many viral diseases. It was dengue, it was chikungunya, and it was Zika, and so. With the climate change, with the extended travel, we continue to cross-pollinate with our viruses and our bacteria across the continent. So it is inevitable. So Florida is no a stranger to, I call it's a gateway to all pathogens from the Central and South America. It's not just the viruses, but it's also unmonitored infections from parasites. For example, Chagas disease is quite prevalent in Florida, and there is a need to continuous monitoring of blood donors. So things happen, and I think people need to recognize. And there's a very nice study too, when in Mount Kilimanjaro, where the mosquito line keep increasing. Anywhere there's colder, there's a mosquito line is increasing. So and the bugs, both not just the mosquitoes, but any bugs and any carriers of infection. So that brings us to, I want to 1 minute to close. Okay, so with that, Matt, that was a very nice discourse on this whole topic, and I think I found it extremely. I mean, I have so many questions, but I said I need to reduce my questions.
You can email me, as anybody else. So feel free to reach out to me if there's a question that's not been answered, or you find a question afterwards. Feel free to email me.
Yeah, so a lot of participants are very grateful for this presentation. Okay, so I would like to thank Dr. Diggle and the audience for attending. A reminder that a link to the recording will be emailed to you and will be available for you to view. We occasionally feature speakers who are not JMM editors, though we tend to stay with Journal of Medical Microbiology editors because there's always a pool of fantastic speakers. Our next session is with Dr. Jo Hobbs from University of St. Andrews, and she'll be delivering a talk on antibiotic tolerance and an underappreciated threat to antibiotic therapy. And this will be on May 30th at the same time. And I encourage promoting this talk to all your colleagues because she really looks at a very interesting point of view, and she's a great communicator as well. And she was one of our Microbiology Society awardee last year, and I really enjoyed her talk last year enough to say, hey, your talk needs to be heard beyond just the confines of the society participants in Edinburgh. So with that, thank you all for coming. I'll see you all soon. I appreciate it. And Matt, hang on for a second, okay?
No problem. Thank you, everybody.
And
Have a
I
nice
thank you for your, yeah. Sorry, go ahead.